Everybody for joining us on a Friday afternoon. That little prompt was firstly to say that we are recording this. Please don't panic. We're recording this just for members of NICON who unfortunately are committed this afternoon, who may want to link later and to really listen in to the conversation. So as Heather said, this is the first of the Grasping the Nettles, and I actually think the 3-year plan is so important that we actually have over 180 people registered for this session on a Friday afternoon, and it looks quite bright outside, and I think that shows that this is a system. All of us, no matter if we're in pre-hospital, hospital, post-hospital care, community and voluntary sector, we're all extremely interested in the direction of travel. I'm absolutely delighted that Jim Wilkinson, who is our Deputy Permanent Secretary and the author of the 3-year plan, is going to say a few words today. Please feel free to keep your camera on, or if you prefer it off, that's no problem. Because we have such a large number of individuals, could I ask that you put your questions into the chat function, and then Heather, myself, and Vicky, Megan, and Robin, who are the workers behind NICON, they will help me try and make sure we get everyone's presentation. I may, and I don't want you to be embarrassed by this, I may call out people. And I've already put Roisin Coulter and Declan McAllister on standby. And if I see a primary care practitioner, they'll also be on standby. But then I would like to maybe redirect some of the questions to members of the audience as well. I think it would be very unfair for us to spend 1.5 hours of interrogating Jim Wilkinson on the blueprint. I think we as a society who want to see a stable, reformed and high quality delivered service, we're all in the mix together. So as I say, recording taking place, questions in the chat function, and if someone is extremely excited to make an opinion on voice, then we will certainly be able to do that as well. So without any hesitancy, I'm absolutely delighted. Jim has been out in public consultations this week in OMA and various events. So Jim, really indebted to you, and we're going to share Jim's slides.
Thank you, Mark. And we wait for the slides to come up.
Yes, sorry, just sharing them now. Just give me 1 sec.
No problem, Robin. Thank you. Well, again, good afternoon, and I add my thanks to Heather and Mark for your attendance this afternoon. Look, I do know the benefits of a webinar lie in the discussion and the interaction, so this presentation will be brief, and it will focus on the purpose of the 3-year plan, its key themes, what it hopes to achieve, and what the next steps are following publication in terms of where we go next. So turning to the purpose, if we could have the next slide. Since the minister took office, and indeed prior to that, indeed nearly every minister, a fairly consistent and constant refrain has been, there is no plan for the health service. I think nearly everybody on this webinar today will know in reality there are many strategies, plans and action plans about what we need to do. Delivering together, making life better, mental health strategy. In fact, Annex A to the consultation document lists 35 live strategies and action plans about what we need to do to reform and deliver health social care. I do think, however, there are probably 2 fair criticisms. Firstly, we haven't articulated clearly what collectively these strategies are trying to achieve. And secondly, we've not been as open about the distinction between what we want to do, what we can do, and what we will do. So in some cases, that can lead to criticism that these are strategies, but in the absence of funding, nothing can be achieved. So how does the 3-year plan add to this? Robin, next slide, please. So the plan describes what we need to achieve under 3 interrelated pillars. Firstly, we need to be realistic and recognise a priority for the system, citizens and the HSC workforce is to stabilise against the pressures that are creating instability and challenging resilience. Secondly, we need to recognise stability as a holding position. It will not deliver the changes we need. Reform must be pursued. And finally, stabilisation and reform don't happen in a vacuum. They must be accompanied by delivery, being as effective as possible within the existing system to maximise the benefits we will achieve from reform. Maybe just to unpick those 3 pillars a bit more detail. Robin, next slide. So stabilisation really has 3 elements to it. The first is finance. It is about efficiency. It is about trying to bridge the gap. We know, for example, last year there was an unprecedented 200 million efficiencies found within 23-24 budgets by all our NDPBs, but particularly the trusts. And this was against a gap we had of in excess of 400 million in terms of the pressures that were in the system. But also, we need to try and look at our financial stability to take away those challenges that it creates and the insecurity it creates, but also to see, can we create some headroom for reform? Turning to our workforce, we need to move away from the annual cycles of pay disputes. But it's also about the future workforce. It's about our training places, but it's also about the well-being of the existing workforce. Those are key components to stabilise and give confidence to our workforce. And secondly, it's about systems, working collectively and collaboratively as a system to improve stability across primary care, community care, and the acute sectors. Winter planning is an example, but one where we need to do more. It's also about a system approach to the challenges we face. If it look like now towards the reform pillar, Robin, next slide. As you'll see, there are a number of key themes, and indeed many of these echo Heather's introductory remarks. Firstly, there's a clear focus on well-being and healthy living, moving from illness treatment to health promotion. It's also about bringing care closer to the community. That means our GP practices, multidisciplinary teams, looking at how we increase our investment in community and primary care, pharmacy care, greater integration with voluntary and community sector, and indeed new models of delivery, how you bring social care services to those most in need. So it is about bringing that care closer to those who need it. In terms of our hospital services, it's very much about ensuring we are organised as effectively as we can. We can maintain the high quality, high standards and high safety delivery that we are able to do for our population, and that we can provide that acute care when it's needed and to those who need it as quickly as possible. That does mean looking at how we organise our urgent care, how we address our backlogs, how we deliver our elective procedures. And it is building on things that are already done. And I think one of the things that we are very keen to indicate is that reform is not a new step. Reform is a continuation of steps we've already made. We know, for example, this year, despite our significant pressures in urgent emergency care, we've already made that shift between separating out where possible elective from urgent and emergency, and therefore our ability to maintain some elective capacity. We've also got our rapid diagnostic centres, and we've got our day procedure centres, all of which are reform, but we need to move and accelerate on it. And secondly, it's also about ensuring that what we do is harnessed in quality and safety. They are not add-ons, they are at the heart of what we're seeking to deliver in terms of a reform. And finally, it is about involvement and participation. And that is right the way through from the system collaborating, involving, engaging in participation, right the way how do we support individual patients and citizens become involved and engaged. Finally, on delivery, if we can move to slide 6, Robin, please. As I've said, stabilisation and reform don't happen in a vacuum. We need to demonstrate that we can increase our capacity. And we've indicated in the document an aspiration to achieve 46,000 more outpatient assessments and 11,000 more treatments. And this is achieved by rebuilding to the service levels we were providing pre-pandemic, but also rebuilding back to levels pre-Encompass rollout. But it also means driving efficiencies where we know already there are efficiencies to be achieved. Do not appears, fail to appears, cancellations. Those are all areas that we know and are within our current delivery model to try and achieve those numbers. But secondly, it's also about stretching. It's about challenging Northern Ireland and saying we are and can be as good and compare favourably with other jurisdictions and other deliveries. And that means moving our deliverable targets towards the average GERF standards in terms of performance across the system. Maybe to reflect on some of the things that we know will have to be in place to enable this to happen. Robin, next slide. So again, those enablers are known to all of us, but they are critical. Workforce is at the heart of the system. Workforce is indeed the key to unlocking stabilisation and reform and delivering, but it's also one that we need to be very sure that we support that workforce. That means both through training, but also well-being, but also providing our workforce with the capacity to innovate, the capability to design, and the freedom to deliver. It's also about that integrated care system. It's creating a new structure to provide collaboration and decision-making and service provision at a system level, both at the regional level and at area partnership level. It's all about improving collaboration and decision-making to sort of enable collaborative delivery. And finally, it is about exploiting digital capability for delivery, for analytics, for system robustness, and indeed for citizen engagement. And finally, it has to be about finance and funding. And finance has been a big piece of the news today and yesterday. And not surprising, it remains an extremely challenging position. And I think we need to really look critically at how we manage finance in a way that enables us to make progress, but also ensures it is not the sole determinant of progress or the only barrier to progress. So what is next? Next slide, please. The purpose of the 3-year plan and the Minister's intent in publishing it was to say that these are the 3 strategic drivers of what we're trying to achieve from the system over the course of this mandate. They will remain constant over this mandate. They're clearly going to be affected by the pace of what we can deliver, both in terms of the external environment and also in terms of funding and finance. But they're not dependent on those. They will remain the key drivers. So it goes back to that introduction that Heather made. It is about health promoting. It is about shifting left. It is about organising reform, and it is about maximising what we can do with engagement and digital services. Obviously, it's critically dependent on funding and our workforce. The Minister is clear that we will pursue this 3-year plan, but that we have to be realistic. So it is both forward-looking, it's optimistic in what it hopes we can achieve with the right support and the right levels of funding by 2027, but it also has to be realistic and rooted in our current operating environment. That's why each year we'll publish a detailed action plan on what we will achieve across those 3 pillars, taking account of the existing operating environment for the year ahead. That may impact on the pace of change, the extent to what we achieve what we set out to do, but it won't change the direction and it won't change momentum. So thank you very much for your time, and I look forward to the discussion.
Thank you very much, Jim, and really grateful for the presentation. And again, I can see that people are out of the blocks already, and we're looking at workforce, we're looking at finance, and I suspect by the time the seminar finishes today, we will have really looked at all of the aspects that you have mentioned there, not just in terms of stabilisation, reform, but delivery. And I see various sectors on the workforce well-being. I am putting Martin Tohill on standby, who will be very keen on that particular area. But I think we'll start off with, I suppose, Jim, the elephant in the room, given the news over the last 24 hours, and that is back to the budget and to finance. So we have a question from Sandy Davey here. And Sandy has asked, look, finance is clearly the airway in this extensive overview. Just as a patient will die without an adequate airway, you can tell he's an anaesthetist, this service will die without adequate finance. Efficiency is important, but can't do any of these on efficiency savings alone. Where will the money come from, and are we really that inefficient? So 2 components to that question. Thank you, Sandy.
Okay, thank you, Mark. And I think it's quite right, and the Minister has made his position clear in terms of the importance of finance and funding, allowing him to make the advances he wishes to. But I suppose, and the 3-year plan makes it clear, there's not one single answer, and Sandy has highlighted some of them himself. We're going to have to pursue efficiency and effectiveness to demonstrate, not least, that it can't achieve everything on its own. And I think our Minister's been very clear. Efficiency and effectiveness can deliver so much, but it cannot create the seismic change we need. It will not impact on the waiting lists that we see. We do need to have additional investment, but efficiency and effectiveness help build the case for additional investment. I also think as we look more challengingly in terms of the funding decisions, there will be difficult decisions about how we prioritise the existing funding we have in terms of making the biggest impact. And that's a real challenge, but one that the system needs to come together to reach an agreement on what is a priority. And finally, and I think that it does point to it, and it's been a really difficult one, is we do need to look at costs and revenue raising and whether or not we can bring some additional resources into the system. And those are suggested across a number of areas. None of those are easy questions, but they are the things that you need to look at when you have to address the challenge that the fuel for reform and the fuel for delivery is finance alongside those people.
And Jim, what I'm going to do is bring Roisin and Declan in now while others are gathering their thoughts and questions. And please do, the more questions we have, the more the discussion progresses. Clearly, finance is particularly important at trust level, Roisin. We have, as Jim mentioned, that 200 million savings from last year looks like it has to be repeated this year. And that has consequences. What is your sort of views on the 3-year plan, and I suppose specifically around the finance, but then maybe the greater component of it as well? And as Jim was saying, it's not all about money. It's what else can we do that doesn't involve money or in some way saves money.
Yes, hi everybody, good to see you all. I'm Roisin Coulter, I'm the Chief Exec here in the South Eastern Trust, and happy to be part of the conversation this afternoon. And for me, I think, certainly from a personal perspective, it would be most useful, I think, if we are very realistic and pragmatic about the position that all of us find ourselves in relation to health and social care at this moment in time. I would never start anything off by talking about money. I think we always have to go back to our core about what is it that we're here for, and that the number one priority, irrespective of all of these challenges, needs to remain patient safety. And secondly, that we need to genuinely appreciate where we are with valuing the workforce that we have across health and social care. I noticed a few comments there in the chat, and that is coming across in probably every meeting that I'm certainly in at the moment, in terms of the conditions and how staff are feeling across health and social care. This cannot be ignored. Moral injury, staff are absolutely exhausted right across hospital and community. And it has been very, very difficult, particularly over the last number of months, with the pressures end-to-end right across the system. So I suppose in that context, where are we within trusts? And, at the end of the day, I think it's very important for us to remember each of us all have a part to play, whether we're Department of Health, SVPG, Public Health Agency, provider trusts, other arm's length bodies. And what do we bring, and what is our core role? So our core role within the trust is we are here to provide services, and we absolutely realise the importance of trying to provide safe services that are clinically appropriate and sustainable for our population. But we also need to be reminded of, yes, there is always there are opportunities for productivity and efficiency. We know that, we recognise that. We've always said we're up for trying to make improvements, be more efficient, absolutely, but that is not enough. And again, there's comments in the chat. We know that is not enough for all of the reasons, particularly in terms of, again, being a provider. From a simple perspective for my own, the demand greatly exceeds the capacity available within provider organisations to deliver. And, you know, in terms of performance management, we absolutely need to hold each other to account across the system, but I can only be held to account for delivery in relation to the amount of capacity that I have available in terms of what's funded and commissioned. And at the moment, across probably every service, that demand greatly exceeds the capacity available for providers to deliver. And that is what has been, I suppose, increasing. And a number of us have worked in the health service, and I see many of you on the screen, that we've seen the demands and the pressures increase year on year. And Jim has alluded to some of the reasons why. And with having, you know, we do have lots of strategies and lots of plans. We know what needs to be done, but it is very rare in a sector where a strategy is developed with no funding stream to implement it. And that is really causing us tremendous difficulties. Mental health strategy being an example, urgent emergency care, cancer, waiting lists, very, very difficult. And there, you know, for me, I feel there needs to be some resolution, and the Minister is doing his best in terms of the media, the messaging at the executive about, and the realistic conversations to say, well, for this amount of money, these are the services that it will buy. So the funding that we have across the health and social care services at the moment, it will not allow us to address the waiting lists at all. And we have the worst waiting lists in the UK, and that's despite the NHS setting money specifically aside for this purpose. So I think, you know, waiting lists and really looking at, we need to find a way to secure the funding to address the waiting lists, because otherwise it's just getting worse and worse. And, you know, I've been involved in developing elective care plans for many, many years. And now, because we haven't been able to put sufficient funding in, then we're seeing all of what's happening at the other end in terms of the amount of funding that would be needed to address the waiting lists. The savings, very, very challenging across the sort of the large trusts, but other bodies as well, having to make significant savings last year in the region of 200 million. None of us were able to deliver in full that ask. Despite looking at and prioritising every single part of our service. So to ask for another 200 million in the context of what we're aware of in terms of the increase in demand, you know, Minister himself referred to this situation, to be quite honest, as dire and diabolical, and that is exactly what it is. So I think what we need to do is to continue to try and work as a system to try and support the messaging. But also, I think it is really time, and I'm sure many of you have seen, there's increasing media across radio, television in the last number of weeks. And I welcome that in terms of, to be honest, we need to have honest dialogue with the public. The public need to understand what is possible for us to deliver, and to be honest, what's not possible. And they haven't, we haven't been able to be as open with the public until now. The public do deserve to know what is possible and what is not. So the situation is not going to improve at all. Small things at the margins, absolutely. And yes, we say all of that. And on the other hand, and always we try to do our roles with, glass half full and bringing, sharing hope. Things that we know work, we need to find a way to develop them, scale them up, and get those services where they need to be. And for me, a couple of those priorities are absolutely multidisciplinary teams in primary care and hospital at home. A priority needs to be providing better services for our frail elderly population in Northern Ireland. They are not getting a fair deal. They are not getting the quality of care that they deserve. And we need to find a way, and I'm determined to do everything I can to make sure that we can have alternatives to older people waiting long time in our ambulances, within our emergency departments, and in hospitals. And there's so, as you all know, it's just so complex, isn't it, to try and do our best. And maybe just to finish by, really reminding ourselves about yes, there's the here and now, but where is all of this going? At the moment in our population, 27 people out of 100 are over 65, but by 2043, that will be 42 people out of every 100 people will be over 65. There's going to be a 39% increase in the pension age population in Northern Ireland over the next 25 years. That's higher than any other part of the UK. So for me, it is really about trying to think, what are these conversations that we need to have? What do we need to prioritise? And some of the things that we are talking about in our trust are, to be honest, we need to revert back to our core purpose, and that we should only be providing what only the health service can provide. And if services can be provided by other sectors, then we really need to look to that. So for me, it needs to be more public engagement, absolutely open and honest, and looking at the need for wider cross-departmental planning at government level. So trying to make sure that other departments, all of that executive, realise that they have got responsibility as well for supporting health and well-being of our population. And I'm not just saying that to pay lip service. I'm saying that that these other bodies and parts of the executive realise that this is for all of the citizens of Northern Ireland. And if we don't do something different, it's going to get worse.
Okay.
That's a starter, Mark.
Roisin, thank you. And there's quite a number of things covered in that. One of the things that I see in the chat, and I promise we're going to come back to workforce because I can see it's a really important focus. Jim, quite a bit in Roisin's discussion there. There were things that I think you will very much welcome, if you don't mind me saying, in terms of what trusts are feeling they have to do at the minute by necessity, in terms of the difficulties that we've had during winter, the fact that there's an executive decision that needs to be made and a societal conversation. Any thoughts or reflections just on what you've heard? And please do keep your questions coming in.
Yeah, well, certainly. I mean, I think the key from all of this is an honest and open conversation with everyone. But it's not a conversation that always is about, despair. So I think there's an honest conversation that says, with the funding we have, we will not make an impact on waiting lists. And our minister's been very, very clear about that. We've estimated we need 135 million extra per annum to buy capacity to address the backlog. And we also think that we need to invest about nearly another 80 million per annum. I mean, these are big sums, but they're not, in the scheme of things, they're not insurmountable sums, to increase our delivery capacity permanently within the system. And together, those two impacts will reduce our waiting lists and raise our capacity. But those are in addition to ensuring we achieve the efficiency and productivity targets that we've set. They also are in addition to, as Roisin's described it, scale and spread of innovation and excellence. They are really, really key, because there is a lot of that in the system, and we don't seem to be able to recognize it, scale it, and spread it as quickly as we could. And I think the other point, and I know I see some of it in the chat room as well, is we can't always have a conversation about what people are perceiving as a front door of health, which is the acute hospital and the emergency department. Within the acute hospital, we actually need to have a conversation which is about the determinants of health, which is public health, which is about care closer to the community. Those conversations need to involve community and voluntary sector. They need to involve primary care, pharmacy, but all working as part of a system. I think the more we can explain and be open to the public that this all needs to work effectively together, and a gap somewhere or a loss somewhere manifests as a problem elsewhere. I think in many ways, I think this is every year, I think people in the system know the challenge of EDs is flow is one of the challenges, and the challenge about flow is the availability of care. But this year, I think the message has really got to the public that big challenge is in community and social care, and we need to look at how we address that. And that challenge is both workforce, because you've got to value individuals providing those services. It's also working collaboratively, and it's working more joined up. So I think Roisin has hit all the challenges. She's also hit on what we need to do despite these challenges. But critical for me is having those realistic conversations. And I think being across all three elements of that 3-year plan, stabilising, efficiency, pushing for reform, allows you to have that conversation, because all too often we have them in silos. We have a crisis talk about how do we stabilise Service X. We have a separate discussion around why is this place underperforming and how can we perform better? And we have a further debate around should this be the right reform? I think we need to keep the discussion active across all of those, but critically, I think we need to have that honest discussion, because there will be honest discussions, I think, need to be had about what services can be provided, what are realistic expectations, what can't be provided, and what, I think, and I hinted at, what can we afford or what can we fund. And I think there is a need to have those discussions with the executive, and the minister's very keen to have that. And I think the more the system is with him in those discussions, the better.
And again, Jim, one of the big challenges we face is we tend to always resort to talking about hospitals, and yet we know that prevention and community and staying as close to home are the key. I'm going to bring in a very wise man called Professor Hugh McKenna, who's on the line. Declan, you're on standby. Hugh, do you want to come on mic, actually, because you've made a very, very important point, and I wonder, do you want to share some comments on that?
Thanks for the surprise, Mark.
You know I love to surprise you, Hugh.
Yeah, a lot of the conversation so far, and perhaps rightly because of the pressures, have been on the acute sector. But as I put in the quote from Professor George Albee from the University of Vermont, famously said that no disease affecting humankind has ever been eradicated by actually treating those affected by the disease. It's about health promotion. And I believe that there'll never be enough beds, there'll never be enough health professionals. So we have to focus in on public health, exercise, diet, social prescribing, and I was really pleased to see that that was the first point that Jim brought up. And I'm also reminded by the Prime Minister of Sweden said that all his ministers are ministers of health. So the Minister of the Environment is the Minister of Health, the Minister of Education is the Minister of Health, etc., etc. So dealing with health is not just the remit of the Minister of Health. It's about getting everybody around the table and realizing that they can all have an impact on the prevention of illness and the promotion of health. And part of that, and Jim touched on this too, is about involvement and engagement. So if you want to move to a more public health emphasis on healthcare, then you have to work closer with the public and do better engagement, better involvement. It's going to be long term, but it can deliver the dividends we require.
Thank you very much, Hugh. And just to bring Declan in at this stage, so I saw a question about, well, why are there 520 beds with decisions to discharge, medically fit for discharge? We have heard, Hugh, about prevention, keeping well, and I suppose the social care situation, and Jim has mentioned that. Any thoughts, Declan, at this stage?
Mark, first of all, good afternoon, everybody. Thank you for actually putting social care on this probably very top leadership agenda, Mark, because that's one of the things that I really do want to talk about today. In terms of social care, it's now part of that minister's 3-year plan. We've been working probably very closely with the department over the last number of years, trying to position social care where we need it to be over the next 5 to 10 years. And Jim's quite right, mentioned about finance and the challenges, but I want to pick up on Roisin's final statement. We need to do something different. And this is the role that social care, and alongside the department, we will be working with the department to really reframe what social care will look like in the next 5 and 10 years. It cannot be seen as a solution to hospital flow. It cannot be seen in the negative media attention around winter pressures. Social care is so much more than that. And for us, it's also about educating our public about the role of social care. We've all felt social care probably at some times in our lives with our families and whatever. We've heard about it during COVID. But as part of this 3-year plan, we've really got to reposition where social care and the part it would play. I want to make a couple of points, Mark, if I may. As the regulator for social care, I'm the new interim chief executive. A bit naive, probably say things I probably wouldn't have said if I was probably a CEO 2 years down the line, but I'm going to say these really important points. The social care workforce is the largest health and social care workforce here in Northern Ireland. It's actually increased by about 23% since 2017. At the moment, our trust colleagues, the 5 trusts, deliver social care with 23% of that workforce. The remaining, that 70 odd other percent, is then delivered by about 400 to 500 providers of small, medium and large across the organisation in private, community, voluntary, independent and charity sectors. Russian's already touched on the demand and how it's going to change over the next 10 years. But if you look at what the Minister's 3-year plan is talking about, we have to think of social care as something that is required. Often we think about it as required at the end of life, but its potential and indeed the actual requirement for it goes much farther than that. When you look at the 3 pillars, for example, and you look at that element of finance and investment and what we need to do to change, we've just published our social care workforce strategy, launched by the Minister in December 2024. We now need to also promote that career pathway for social care, that element of qualifications, not seeing social care workers, and that was the old term, as a pair of hands to support nursing, to support AHPs. Our social care practitioners, which is the term that we will be using going forward, they need to have that support, that education and that qualification to really be seen as sitting at the same table with the same power, the same intelligence, the same knowledge to shape care planning, etc., as the rest of that multidisciplinary team. We already have seen the relevant work and the potential investment that will come into social care. We cannot see social care practitioners in the same vein as we pay our colleagues in Sainsbury's, etc., packing shelves. Our Minister has talked about an investment of almost 50 million, at least bringing our social care workforce up to the real living wage. Individuals out there delivering frontline services within social care, it's exactly the same, whether you're working as an AHP in the trusts, etc. The challenges are immense. However, we need to actually really reflect on their recognition, what they do, build in qualifications, and we believe that we will see a workforce that sits alongside our nursing, our medics, our AHPs, and actually potentially could be one of the key solutions for how we deliver care in the future, and perhaps within the same size of cake in terms of finance that we currently have.
Declan, thank you so much. Really grateful to everyone. We have 109 people on this webinar. That is amazing. I'm seeing people from all of our trusts, all of our primary social care. We have medical directors, we have directors of trusts. Fantastic. Jim, some reflections on really important messaging from Declan.
Yeah, both Declan and Hugh. It's no mistake that the Minister's strategy starts with public health and then starts with care closest to those who can receive it. And that is because it's very much about recognising the public health message. And within the public health message, it's about keeping people well. It's about recognising the demographics as Roshan's outlined and really promoting healthy life as long as we can have that. And it is about working across departments. So the Minister has 2 healthy living initiatives ongoing at the moment. He said, as made it clear, he's starting those with what health and health promotional interventions we can do, working with communities and engaging with communities to say what is it that would make a difference in your area. But he's also made it critically clear that healthy living goes beyond that. And as Hugh suggested, every minister is a Minister of Health. And already in those pilots, we are having discussions with the Department for Communities about the role of ensuring people have access to the correct benefits, but also about pathways into employment. We're having discussions with the Department for Economy. Again, similarly, about the role of education and skills and reskilling and helping people have pathways to healthier lives and also pathways back into employment. So those debates are happening, and they're all happening within the current budgetary envelope of all departments. So there's something about that. In terms of what Declan said, I think it's absolutely critical that the role of social care, it's not, I mean, we've referenced it, it's been raised in the profile about the role it can play in helping address acute pressures, but that's not where it's referenced in the documents. Where it's referenced in the document is as a key enabler in shifting care closer to home and helping people stay in their home and helping people get home after acute incidents. And that's where it needs to be valued. If that's the case, then you need the skilled workforce to do it. And you need a workforce that also has all the incentives that are needed in terms of to maintain and stay in that as a career pathway and recognize qualifications. So they are embedded in that system, and certainly that is what's set there as a priority. At the same time, we have to be realistic, and I think it's always important to give messages about what we want to achieve, what our aspirations are, and then every year say, what are the steps we can make towards that? Be they incremental, be they small, but keep pushing in the right direction. And that's where the challenge around budget comes in. But I don't think we can't let budget derail what is the right thing to do, for example, in social care, about those pathways, about those wages. Similarly, we can't let budget derail what is right to do in terms of health promotion and living well. But it will, and we have to be honest, it will impact on the pace and scale of what we can do.
Thank you very much. And I know Brona Scott has made some commentary there around scale and pace. I'm just going to put Aideen McGinley and Tom Frawley on standby because we've had a mention of the conversation with society, conversation with our public. What is it that the health service can do and is able to do in the short, medium and long term? What is the expectations of our public? But I'm going to zoom over to Heather first for a little roundup of some of the commentary in the chat function. Please bear with us. You're all doing really well with 45 minutes to go. Jim is still standing. All is good. Heather?
No, I mean, I think we've begun the conversation well. The focus for me has to remain on those three shifts. I think, you know, building on Hugh's focus, we can tend to get a bit focused on hospital because that's what we see. Really working with partners, I would love to see us, and Bernie Kelly's online. She could maybe talk a wee bit about the role of the voluntary community sector. A lot of light touch work in communities can make a very big difference. And the whole, I've just popped in the chat, the wellbeing framework for the programme for government. So how does government reduce the duplication and bring community approaches at local level, which will be sort of in our integrated care about community planning, but lots of the other parts of government are doing that. So maybe could talk a wee bit about that. I'm also very interested in how we talk about public health in health, because the Public Health Agency leads on it, but there's health inequalities, there's public health, there's health improvement. You know, how do we work with our partners? What's our response to all of those things? So it's really, Mark, for me, also some of the enablers about how do we really lean in and find a culture for ourselves where we're empowering people. So probably like me, you're around the system, people have good ideas and then they get stopped. So what is it that we could do to really reach in and to help everybody to really bring their discretionary effort, as when they are in their work, they can find ways that they can bring innovation and support as well. So those are the things that are coming out. Obviously, we'll maybe come back to the workforce because that's a massive issue for everybody.
I think we will come back to workforce. I see Mr. Armstrong's return from theatre. So we will come back to the workforce because I do think that's really important, and it covers everything I see in the chat from social care terms and conditions. I do want to bring Martin Tohill in from a well-being, a staff well-being point of view. Aideen and Tom, maybe we'll go ladies first. Aideen, this 3-year plan, the reconfiguration document, various reviews have all taken place. And we as a society know that change is needed. We talk about stabilisation, reform and delivery. Is there anything we need to discuss today as a system from the department right down in terms of communication with the public? And is there an understanding at parish level that change is needed?
Well, first of all, thank you for putting on these seminars. I'm actually in Boston, so I'm early morning sunny here, but I really was keen to listen in, because the whole systems type approach, we talk about it, but we just don't do it. A couple of things Jim mentioned at the very outset in his presentation, the number of strategies. We've no lacking of pieces of paper and writing on them. And indeed, it reminds me back in Derry 10 years ago in the One Plan, and we had 72 different strategies for the city of Derry that we managed through a huge process of engagement using future search type techniques to get it into one plan, which is why Derry is actually doing so well strategically now, because it managed to focus, but it's hell of a lot of hard work. Then from the parish, and I'm involved in a number of charities at a very local level in my home place in Fermanagh, and not least the issues relating to the hospital. If we genuinely don't, I mean, for example, Pathfinder was a brilliant example of best practice in terms of partnership, and it just got lost. We've thrown so many babies out with bathwater because we automatically think we move on to another strategy. I think this is roll the sleeves up. It's genuinely talking to people. We leave some people out of the discussions because we're afraid of the risk that it takes to bring in, for example, the private sector. You know, we don't have enough entrepreneurial spirit in here. There are people out there delivering social care in packages who are full of entrepreneurial ideas, who are doing it for not just from a money point of view, but genuinely a heart. One example of someone who I have huge admiration for is the like of Jennifer Neff, who has been doing social prescribing all over the world, but finds it very difficult to get a grip in her own home place. You know, it's identifying different people to be at the table. Too many of us have seen each other for too long over too many tables. How do we get that injection of innovation and a spark that goes from the parish level up? Welcome the ICS and the reintroduction of it, but it's heavily bureaucratic. It's been you know, we kill things with bureaucracy. We really need to be nimble. 3 years is not a long time. Where are things working? Put the efforts there. Sustain support where there's capacity, and as you would expect, I'd be talking about SWA here in terms of waiting lists, etc. There's huge opportunity for capacity there and cross-border opportunities. Where's the opportunities? Go to them, take the risk, put the money in, spend it, get things starting, and you will be amazed at what the community and the other partners will do once they're allowed to do it.
And I'm going to bring Tom in and then back to Jim, because I think really important points. And maybe Northern Ireland is small and profits aren't welcome in their hometown. I'm not sure, Aideen, maybe we need to challenge that. But I was going to say the father of the house. Is that appropriate, Tom? We'll bring Tom in. Is your mic on, Tom? Yep,
can you hear me now?
Hear you loud and clear.
Yeah, well, I mean, I think it's trying to contain the energy and the enthusiasm of these young people from Fermanagh becomes a task in itself. I do think that, you know, that Aideen makes some very powerful points. I mean, we're brilliant at inventing wheels, but we then sort of pass on to the next one. And we're not great finisher completers, I think. We put time frames on things, and because they've endpoints, we stop at the endpoint instead of saying what's working in that and how can we maintain and sustain that over time. I mean, the reality of change is that people don't like it. Let's not kid ourselves that people are comfortable with change. And anything that looks like a reduction in the resource infrastructure that they have is something they will resist. And I don't think we're very good at communicating what we're trying to achieve. And I do think we tend to look at things from our own local parish context, as Aideen has said. So I think trying to find the language and the vehicles to communicate more effectively is a huge part of getting the community on side. And I agree with her entirely about the same faces appearing, myself included, and the need for fresh faces and how we get fresh ideas in. I mean, I think her thoughts on the cross-border opportunities are very, very real. And I think it's something talking about entrepreneurship, I think we have to be entrepreneurship. When you look at the success of the cancer unit here in Derry, and there is a huge pressure and I think interest from the Republic of Ireland in expanding that service for its people in the northwest of the Republic. And I think other services equally, we really have opportunities there to enhance it. The problem is, going back to the staff's side of this, we're losing so many people to the Republic of Ireland because we are losing the battle in terms of pay and terms and conditions that are much more attractive in the Republic of Ireland now than they are in Northern Ireland. And that's something we need to be much more alert to. But I think that, in a sense, the one thing that I would worry about on the financial side of things, you will create a sense of hopelessness if you make an ask of people that they believe is not deliverable. And then the energy and enthusiasm you need to make progress in this very challenging space will not be available to you. I think a number of people have commented on the chat line about the morale of people and the morale of the organization. You know, if you keep doubling down in a way, and we want the same again, and we want the same again, then people will say this is not doable, and they will either walk away or they will give up. And I think we need to be very careful in the messaging and what we expect of people, and that particularly applies to our politicians. And if I may say so, it equally applies to the media. I mean, I heard a very interesting debate at the very end of The View last night, where interestingly, it was Sam McBride and Newton Emerson were saying, we have created the most complex bureaucracy on earth in order to effect change within this place, that everyone has an opportunity to challenge and reject. And so we have created the most defensive civil service, defensive public service, because everywhere they turn, there's a judicial review waiting to be leveled at them. And I think we really do need to look at that architecture and simplify it to make change not easy, but to make it doable and believable, and then really change that risk aversity into a recognition that, you know, when you make omelets, you break eggs, and there are going to be disappointments and concerns from people in certain parts of that agenda, but you have to have the courage to face that down because you believe what's beyond it will be better for the people we're here to serve. And I do accept the point made again by Hugh McKenna that we realize, you know, we have dismantled huge infrastructure around health education, which was much more, when I was in this world before, much more orientated inside locality and inside place, where it actually works much better than when you go for big initiatives, which I think are very hard to get traction for. I always remember the example offered me by the most successful health promotion piece in the Republic of Ireland during the late 90s was the giving up smoking for people at school. And what they did was they brought the Leitrim Gaelic team into a hall in Manor Hamilton, and they brought all the school children of the ages between 10 and 15 in, and they gave a Leitrim football jersey to each child, and then told them they were playing for Leitrim, and anytime they smoked, they were conceding scores by Leitrim, and it really had traction. Now that's a simple idea, but unless we can get you know, that message across in a more accessible way, and I think, as I say, a more local way. I mean, what shocks me about our health today is I've never seen people take, and I know there are many who don't take it as seriously as they should, but there are lots of people making huge efforts with their health. And, you know, that's a positive thing. So I think there's so much more can be done in that space. And I think the Prime Minister of Sweden got it absolutely right. This idea that this is only your business, Mr. Nesbitt, is a shocking reflection on the system. And I think that's something that we in the service and in leadership need to be saying to the wider political community. You all own this health agenda and you all have responsibility for delivering it. And it will not be delivered if you continue with a model that says, oh, well, poor old Mike, you know, when you look there as a sad health service worker and you wait for them to allocate the health portfolio in the Great Dahont experience, and you're down at number 10 and 11 before the poor man with the one portfolio puts his hand up and gets the job. I mean, that says something really serious about our political population.
Thank you, Tom. And I suppose a couple of things there. The cry for Team HSCNI, the cry for us as a society to take the responsibility, and really one of the aspects around bureaucracy. And Declan has reminded us of Raphael Bengoa's comment that, the leadership keep the outcome tight, the outcome or the direction tight, but everything else flexible, open and innovative to try and bring it about. And I know that's music to Jim's ears, and he certainly doesn't disagree with that. Jim, comments before we bring in Bernie Kelly, and then keep your questions coming. I do want to finish on workforce, both within hospital, and I see a number of hospital clinicians, within social care, and in fact, interestingly, we have gone into this discussion for 1 hour and we haven't mentioned primary care yet. That's pretty amazing, but we will come on to primary care too. Jim.
Yeah, well, I mean, I think firstly, just to pick up both on the points that Aileen and Tom made, I think it's exactly right. There is an issue here about unlocking potential, but there's also an issue about open and transparent communication. And I think in some ways, the answer to both, I think, will help as we get better at explaining ourselves and better at using data and outcomes to tell us what are the right things to do. Because a lot of times what we have is something worked well, but it's a silent message and a silent piece of data that says this is the right thing to do. So we really do need to get, I think, clear about, as Tom said, change is difficult, and change is hard, and change is resisted. But part of the answer to that is being engaging within individuals about change, recognizing their points of view, but having the clear data and evidence that says this is the right thing to do for the population because it'll make the right difference. Because if we don't have that, there's no point. We wouldn't be doing things. And I think the same holds true, not just for engagement, but also for innovation and for spread, and to make the case that doing something different is the better way to do things, be that social prescribing, be that collaboration, be that partnerships that you don't usually make, be that using money in an innovative way to collaborate on something that may be slightly outside your ability but will make the difference. And I honestly think if we can win those discussions at the local level and say somewhere like a Live Better pilot, and we see benefits offices, careers offices, local schools, health trusts, community groups working together to do health promotion, it makes it a real strong case to the ministers of those departments to say, well, if your folk on the ground can innovate and deliver, then clearly there's a role for every minister to play in a joint agenda. So I do think there's something about communication, there's something about enabling innovation, and there's something about data making the case that we need to get better at utilising. I think funding is always a challenge, and the one I would put back, and I hinted at it in my conversation, if we're facing difficult funding environments, and we are, if there's a massive gap and it's difficult to bridge, there's something about deciding early on there are certain things that are so important to fund that we will prioritize it. And there is a debate, I think, to be had around recognizing the critical importance of a lot of our acute services and the value they have, but also recognizing there's something critical about health promotion, there's something critical about social care, and they may need to be prioritized within the limited funding we have as well.
Thank you, Jim. And clearly, we concentrate a little bit there on funding. And I suppose one of the dilemmas of a restricted budget on a yearly basis is the decisions that sometimes have to be made that are counterintuitive. And I want to bring in our voluntary and community sector because, again, our voluntary and community sector are as massive a part of our delivery of well-being and the reaction to illness as anywhere. Bernie, do you want to come in and just say a few comments? Yeah. And then I'm just putting several medical directors on standby because I would like us to get diving into some of the workforce issues that we face.
Okay, thanks, Mark. Well, I'm here on behalf of the CO3 Group, which is a membership-led organisation dealing with leaders in the third sector, developing and supporting them. And that's a wide range of organisations, the charity sector, voluntary and community sector, and social enterprises. So I chair the Health Special Interest Group, and there's over 70 organisations in that group alone. So what happened was we commissioned, through dormant accounts, commissioned a significant piece of research and consultation in the sector, and highlighted that there was a desire to work, I suppose, in a more unified way and get better representation. So also to share best practice and to, enhance collaboration. And we need all the sectors. The challenges that have been well articulated here are so great that no one sector can, have the solutions to all of them. Our members are highly skilled. There's a lot of them on this call today. Highly skilled, dealing with more and more complex. A lot of them, they deal with policy advocacy, but a lot of them are delivery organisations dealing with very complex situations. Declan has articulated well the social care sector and the problems and the need to skill up. So we want to support the sector. We think, but clearly they do want, better, appropriate recognition and remuneration. So to that end, and the department has provided some funding to us to sort of do that work in a more cohesive and unified way. And we have a post out for recruitment ahead of the NI head of Health Collective. And there's a bit of a plug here because we're recruiting. The deadline's the 30th of January. And I'll put details if anybody wants to email me, I can send a pack. But that's with the aim of, again, strengthening the voluntary and community sector, because there's excellent skills out there, and we do want to work across the sectors to support the challenges in health and social care.
Bernie, thank you so much. And back to Jim. Any comments there, Jim?
Again, I think it just stresses, and it was part of the enablers. I think on my last slide, I said really success is going to be about collaborating, and it means collaborating in the widest sense. And I think one of the messages that has certainly come through in nearly every challenge that we faced over the last number of years has been that collaboration is undoubtedly an enabler and a key, and the more widely that collaboration happens, the better. And I think it is about viewing partners and having honest conversations about what collectively can be achieved. It's something that will be central. And as I've said before, I think sometimes those discussions and those partnerships are easier at a problem and local level and become harder as we move further up the decision-making tree. But if we want to unlock some of that bureaucracy that Tom referred to, we've got to sort of be able to pivot towards that sort of collaboration and collaborative decision-making.
Thank you very much, Jim. Guys, we still nearly have 100 people on a Friday afternoon at 3:08, and I think that just says that we have a workforce that is willing and ready. And we've had a lot of discussion that has hinted at the changes in this 3-year plan. Yes, funding is one of them, but the will of the people is another, and that is the staff. And there's been several comments around the workforce and staff morale, and we've seen many reports in recent days of some of the challenges. Martin, I want to bring you in first as an occupational health consultant, if you don't mind, camera on or off, whatever, Martin. Just around, you're seeing this at the cutting edge of staff wellbeing. And then maybe Steve Austin might want to give a reflection, or Aidan Armstrong, someone within hospital. And then Roger, I'm afraid, if I can look I don't see any GP. Forgive me if I've missed a GP, but you might have to take up the mantle for primary care. Martin, a few comments?
Martin's had to step away. He's chairing another meeting, Mark.
Oh,
so
no problem.
We pick up with him afterwards.
We'll pick up with him, no problem. I'm going to run to Steve. Are you listening, Steve Austin? No. Steve's talking to somebody by the look of things. Aidan, do you want to come in just around workforce? I've ambushed you and I know you're in between theatre cases.
Well, I don't particularly want to, but since you've asked, I think there are inherent dangers with the use of the word burnout. We know people are suffering workplace stress, but I think we've all got to be very careful about using that word in a way which becomes a self-fulfilling prophecy throughout the system. And that's only a brief word of caution. If we look at surgery, which is obviously what I'm most interested in, nationally surgery is in trouble in general surgery, and regionally general surgery is dying. We have massive recruitment problems within surgery in Northern Ireland. Outside Belfast, even the biggest DGHs are now really struggling to recruit consultant surgeons who will be there for a long period. This isn't just due to remuneration, but we've talked a little bit earlier on about workplace environment. People go into surgery to do operations. And in Northern Ireland at the minute, we have a uniquely unfavourable position for surgeons where we're doing less operating than anywhere else in the United Kingdom and being paid less than anywhere else in the island of Ireland. And I think that unless we look at those two factors, we're going to have an enormous problem with the recruitment of a surgical workforce over the next 5 years. And at the recurrent rate of attrition, one of the large DGHs will be left without a sustainable surgical workforce over the next 6 years. That's Antrim, Derry, or Craigavon without a surgical service.
And again, Aidan, that is one area of specialisation that there is grave concerns about in terms of workforce going forward. Steve, I know you were...
Mark, could I just jump in there? Could I maybe ask Aidan to reflect about clinical leadership? Do you think we're doing enough, or we're good enough, for their opportunities for really supporting our clinicians to be leading change? I hear that conversation a lot. Be interested in what you think.
And we'll ask the same to Steve Austin if he can hear me okay. But Aidan, go first.
Yeah, Mark will know I have a particular difficulty with anything to do with the word leading or leadership. It seems to me that leadership is one thing and we can lead without authority. But I think there has been a failure to grasp the basic statistics, which I've just alluded to. And we cannot lead unless we are leading in a particular direction. And that direction has to be based on the idea of what we need to keep alive and what is currently dying. But in general surgery in Northern Ireland at the minute, we are dying, and one of those three enormous sites will die within my working lifetime unless we do something about it.
And I suppose what I want to do is help Jim here, because Jim is sitting in the Department of Health and we have got every facet of our system feeling the pinch, the pressure. And Jim asked a very subtle question, which is, what do we stop? What do we do? What can we do within current budgets? What is sustainable going forward? And it is the interlink around stabilisation. I would suggest stabilisation requires reform. It's not we stabilise, then we reform. And I know that's not the way the 3-year plan's written, but the questions that we have around that workforce, and you've given a very stark, but I believe factually correct opinion about general surgery. Steve, any comments around workforce well-being, workforce direction? And then a question to all on this is, Jim Wilkinson sitting there getting inundated from every facet of our system of delivering health and social care. This 3-year plan has been put out. Where do we make the decisions, or who makes the decisions, or who accepts the decisions that need to be made to sustain? And then I'm going to bring Roger in from a primary care. Steve.
Thanks very much, Mark. You're very correct that one of the things is about the well-being of our staff, and that's doctors, nurses, physiotherapists, and social workers, and all. They're under enormous pressure at present, and I think Aidan's sort of highlighting that as well. There's various issues that staff are working under, the conditions they're working under are stressful, and then there's the grass seems greener elsewhere. And that's part of the problem with this. Sometimes the grass isn't greener, but once you're gone, and that's the difficulty you have. So one of the things we can try to do is try and make the conditions and work that people do as good as we can, so it's more attractive, to give them time and space. And sometimes there's so much clinical work to do that staff don't have the space to think differently and to get the part of the work is trying to change their services. So like at the start, Jim, you mentioned about the outpatients are going to be more efficient and so forth. But sometimes it isn't always just doing more of the same. It's about doing something a bit different. So is it about trying to think about, it's not always about outpatients appointments, because if you talk to our GPs, quite a lot of the appointments they don't actually need to send somebody outpatients, but there's no other choice. Can they get advice and so forth instead of having to use up an outpatient appointment? But the trouble is that's not recognised in commissioning models. So consultants can spend oodles of time doing all this advice work and phone lines and consultants a week answering that, but it's not recognised, and they don't really get recognition of that in their job plan. So it's not supported. That needs to be sort of changed, the model, that actually there's a value in that as well, rather than just doing the outpatient, the old models. Such patient-initiated follow-up is really important to think about as well. This Encompass is going to give us some opportunity as well, how we can try and do that. But staff do need time to be able to think about how to do that. And if they're so busy on the wheel doing the work, they don't have time, the space to think, well, how can I modernise, improve my service? They do the innovative stuff that some colleagues are trying to do, but they're doing it outside their normal time. It's really, really challenging. So, and then they get burnt out. So the people who are really good doing all this stuff, they just get burnt out, or services dependent on them. But staff are really, if they get an opportunity to do innovation and so forth, that does give them a bit of real buzz to try and make a difference for patients. And that's one of the things we can do. But it's also, you need support to do that, and you just can't be doing that plus the day job and stuff. So we need to find time to focus on that. So that would help, Mark.
Yeah. Absolutely, and thank you, Steve. And that is echoed by Eunice Minford, talking about patient-initiated follow-up in the chat function and doing things differently, and even bringing in the anticipatory care planning about patients coming into hospital. Should they be in hospital? Have we a plan for our frail elderly population? Declan's heart will be broken with us talking about all of this. Is it the right place in a trolley or the back of an ambulance for a very frail elderly person with dementia? All of this is in the mix. A little bit of reflection on primary care, Roger. We are coming into the last 15 minutes. You'll all be glad to know coffee can happen. But Roger, you probably could talk for the next 15 minutes about primary care, but we're going to ban you from doing that. Primary care.
Yeah. I mean, Mark, I don't want to get bogged down in demand, capacity, indemnity, national insurance, and access pressures, funding baselines, etc. But if I may just briefly, a couple of reflections on the discussions that really resonate with me, and I know Jim will know some of this from our travails in previous work. To get anything done in the system's hard. To change anything, it's hard. And, that needs recognised. It does take time, it does take courage, and it certainly takes that collaborative approach, Roisin, and particularly looking at our journey in MDTs with South Eastern Trust. So it's in the hard to do box. And just a comment that Tom made that really resonated with me, and his analogy was break eggs. Well, yeah, we've got to break eggs, and we've got to disrupt and manage disruption on occasion to get things done, as long as people are fully sighted and on board with that. So a couple of observations, Mark, and if you don't mind, happy to talk about MDTs and in terms of that innovation. So we're still hopeful that we'll be successful in the transformation funding. Our journey of change, as Jim will know, has been hugely challenging to build that strong evidence base to not only support the future transformation bid, but essentially picking up on some of the chat room, that we're in a position now to go at some more pace and scale in terms of rollout, and that's been challenging. So I guess one of my messages in all of this, you need support from information, HSCNI. You need to be able to build your database, and that's hugely challenging for professionals, Mark, trying to deliver change and produce innovative ideas. That's maybe something that we can reflect on and take away as well. And in terms of the programme, this is about building a capacity within primary care, obviously, within general practice, but it is also about improving the health and well-being and creating a platform for change. And that has been quite exciting over the last few weeks in terms of our partnership with the mental health strategy, for example, the Live Better, and our partnership on that. We have addiction colleagues knocking on our door, thinking about what does that interface look like. We had huge discussions, positive discussions with our divisional social work needs, Mark, leads across all of the trusts, who perhaps early and not so long ago seen us as a threat in terms of that workforce component, but now see us very much as an opportunity for further change. So I think that, you know, our position is about that platform and is about the art of the possible as well, to promote that wider change agenda.
And Roger, thank you. So the art of the possible, we've already heard from Steve, and while some may disagree with the mechanism, there is no doubt that with Encompass, we will have a single electronic care record for Northern Ireland, unlike our counterparts in other parts where there are individual systems. And I believe Australia are now looking towards here for that example. Sandy has put some comments in the box about taking that technology forward. Shiva has made some really interesting comments about technology scientists employed within the system, but yet again, that is one of the areas. The other area is that rollout of multidisciplinary teams, as you have said, in terms of primary care stabilisation and reform, I suppose. Jim, reflections on sort of workforce from what you've heard so far?
Yeah, I mean, there's a number of reflections, and I want to go back to one of the comments Roisin put in it. I think in terms of workforce, you know, we've got to go to the entire system, and I think that starts with being clear what we're commissioning in terms of training, and then providing that quality training, and then providing that through flow into the system. But I think we also have to look at the reality and say, if we know what the challenges are and what the issues are and what the dangers are, being realistic about what we can do with them. So there's some discussion around the danger of significantly more attractive, you know, and I think Steve even said, you know, seemingly more attractive. So there's something about understanding and articulating the package that if we can't change the packages and what's available, then we have to package it in a way that we explain it fully so that people are making rational decisions. The second, I think, was about freeing up consultants or consultant time to do that which is of most value, be that operating or be that innovating. And I think the question there is, okay, what's the barrier? Let's talk about the barrier rather than what the innovation is. And that's that being tight on what you want to achieve and loose on how it's achieved. So lots of times we get drawn into a detailed debate about, well, what is the thing that will work particularly well? And it may be nuanced. I think the better question to ask is, what's stopping this happening? And how as a system do we address some of those issues? I think turning to the issue of primary care, and in particular, and innovation, I think undoubtedly we put in structures. So the ICS is a structure, it will be a bureaucracy. But the question is, how do we make the bureaucracy work effectively? I think what the structures do, though, is say, we think it's so important that there should be collaboration between the community sector, the voluntary sector, the trusts and the acute, that we're going to put a structure around it and give it some legislative authority. But I think the key is, how do we make those structures work and how do we make collaboration work? And part of that, for me, and I come across this, and I'm never sure, it's never really overt, but sometimes you get the impression in working out what is good, that some people say, well, if I say something else good, then I'm lower down the pecking order, and that actually it's a competition for funding Whereas I think it should be a competition to support what's good, what's the next good thing, what's the next good thing, rather than suggesting a winner one place can be a loser somewhere else. And I think Roger's indicated that may have been a perception at the start in some of what we were doing in MDTs, and it's certainly moved on from beyond that. But I think nearly every change and every proposal, because there's so much pressure in the system, we have to get over the fact a pound spent somewhere isn't a pound lost for spending in some other pressure area. It's just a prioritization.
Thank you, Jim. We have about 5 or 6 minutes left, and I really want to think outside the box now, if you'll indulge me. So we've heard from the spectrum of our system, but we've also private sector colleagues on this call today. And we've already heard from Aideen about Jennifer Nath and social prescribing. And I'm maybe going to suggest if one of our colleagues from industry wanted to say a few words, because sometimes, and we talk about bureaucracy, sometimes it's a really difficult mix of the system and our procurement, and yet what individual companies can and do in other parts of the United Kingdom. Does any of our colleagues from industry want to come on?
Mark Mackelholm would be a good person to pick on if he's...
Okay, you've picked on him. Is Mark there?
Picking on him. They're working right across the UK.
Mark, have you your microphone off, or have you run away? Mark has.
Hello.
Maybe... Oh, there you are.
There you go.
Mark, you've been nominated.
Sorry, I had to go and lift my daughter at 10 o'clock, so I'm still listening, but I'm driving. Firstly, a very informative and, to be honest, frustrating listen, but some fantastic comments from everybody. And I think everybody has, it's quite obvious that everybody has the appetite and ambition to change. But I think from looking out from the outside, I would say that things are slow. Innovation is slow. It's sometimes frustrating for us to look out and see things like, for example, somebody mentioned there about integrated care. In England, integrated care systems have been about now for several years, and most of them haven't really made a big impact. And you see that in Scotland as well, I believe. So the social care challenges are very, very similar in all parts of the system across the UK, and that's frustrating because from our part, we see lots and lots of pockets of really good innovation, but it's very hard to spread something that's good and happening in one organisation to another. And I think there needs to be maybe some work done and a forum really where somebody can share that. And as I said to Heather before, somewhere where we can ask stupid questions, because sometimes stupid questions breed good ideas. And I'm not really saying anything of value, but it's just really, really good to be in and listen to this and hear everyone's frustrations. But it's the question now is really, what do we do? And the private sector are very much part of that and want to be a part of it, and we want to help. And I would encourage everybody to try and reach out to your private sector partners and involve them in some of the solutions that you're trying to find.
And I think, Jim, you'll want to come in there, because I know that that's not an alien concept in terms of department and discussions.
No, it's not. I mean, I think from every aspect, I mean, we've already said that we know to address some of the challenges, we have to work with private sector partners in their health regime, but also we're very much aware that we need to learn where something's worked. We need to learn, and we need to learn from private sector companies that have been working with the health system. One of our challenges, but it's only a challenge, it's the same question I pose to the system: what's stopping you doing it? Is to look at why is it we don't do so much of this? What is it about we need to do about our sort of procurement and engagement rules that allows those open conversations to harness innovation and allow it to be spread? And certainly that's a discussion I know that Peter May has had. We have, as you know, a transformation advisory body, improvement and transformation advisory body. On that, we have industry, and one of their calls and one of their questions is, how can we work better with you? But how can we work better with and help solve the solutions with an ability to move the solution into action pretty quickly. So those are open discussions that are happening both at a strategic level, and I think also needs to give the authority to have those and freedom to have those discussions at a local level. But it's undoubtedly something that has a part to play in terms of helping us all work better and identify solutions that can be used and can be applied.
Thank you very much, Jim. Thank you to everyone. I'm going to give Heather the final word, but I want to just thank everyone. Can I also thank you for the chat function? We've actually seen scaling up best practice taking place on that chat function. Sandy Davies is linking in with Roisin Coulter. Declan is linking in with, and so it goes on. Now, I am a man, I could only unitask, so I haven't been able to keep abreast of the chat function going on, but there does seem to be quite a lot. The other issue is no matter how the storm raged yesterday, nor how dark and cold the night, the sun will always rise in the morning. And again, 95 to 98 people still on a Friday afternoon, all looking towards developing and changing and doing all we can to turn this ship around. Any final closing comments, Jim, before I hand over to Heather?
No, other than, I think it's the sort of ending with the start, which was the minister's published this as a 3-year plan that he wants to maintain focus on during the length of this mandate, and he wants to continue to make progress across it. You're right, Mark. It is 3 pillars, but as I said, they are interdependent. Stabilisation is interdependent with reform. Reform is interdependent with delivery. They all have to happen in tandem. And I suppose I would add, the minister will continue to make the case for investment to advance all of this. But I think steady progress, showing commitment as a system towards this, a sort of a common message that these are the right things to do and this is the right way to do it, all strengthen that case that he will be making for funding. And as we start to deliver and promote success where we see it, that also adds to that support for investment and more delivery.
Jim, thank you very much. Thank you to all our contributors. Apologies if we bullied you to speak. Really appreciate that contribution. And it's all Heather's fault. Heather, final words.
Yeah. No, as Mark says, just a massive thanks to everybody. We are really keen to the energy that we can get at NICON, just that social movement where everybody gets excited and then you go back to your day jobs. We really want to harness that. So hopefully we can build these conversations. Please, where you have your ideas, we can sort of develop these. You can see people cross-checking. And I think what is exciting for me is we're having voices from so many different sectors and opening up. So that's something we really want to do, to just lean into that. So thank you so much for coming with us. We'll send you the information about the rest of them. But again, if there's other things that you want us to do, we can take a focus on different things that everybody can share. So thanks to all our partners, Jim and Roisin and Declan and Mark as well for sharing for us today, and have a fantastic weekend in the sunshine. Okay, everybody. Cheers. Thanks.
Thank you.
Bye, everybody.
Bye.